Hello, my name is Dr. David Partrick. This is Dr. Chris Derderian. We are two of the pediatric surgeons here at Children's Hospital, Colorado. Today we are going to be discussing congenital pulmonary airway malformations, also referred to as CPAMs. Dr. Derderian is one of our surgeons in our fetal surgery group who get involved in these patients prenatally, and then the other pediatric surgeons are often involved in these patients postnatally when it comes time to potentially have surgery done. But I will have Dr. Derderian talk about the prenatal workup and management of these patients first.
Thanks, David. So CPAMs are lung lesions that are often identified on prenatal ultrasounds. They can be picked up at that 20-week screening ultrasound, and that's oftentimes the time at which they're referred to us. They can be referred to as microcystic, meaning they're predominantly made of small, tiny cysts within the lung tissue. Alternatively, they can be macrocystic, where they have large, dominant cysts within the lung tissue. And then lastly, and fairly commonly, we see a combination of the two. So the lung tissue will be composed of both microcystic and macrocystic, or small and large cysts. When CPAMs are identified within the fetus, we monitor them extremely closely. Occasionally, we'll obtain an MRI of the fetus to better characterize the lesion, specifically when the diagnosis is in question. During fetal growth, CPAMs continue to enlarge up until about 28 weeks of gestation. After this point, the CPAMs generally stabilize and occasionally even get smaller on their own. And for this reason, we follow these lesions extremely closely up until about 28 weeks, with weekly ultrasounds at that point. If the lesion's stable, or if it's regressed in size, we'll spread those ultrasounds out. To describe the size of CPAMs, we use a measurement referred to as cyst volume ratio, or CVR. And this is just a measurement to adjust for the size of gestation and give a description of the size of the mass itself. Lesions with a CVR of less than 1.6 often remain asymptomatic in utero and even at the time of birth. Larger lesions, measuring those with a CVR of 1.6 or greater, can cause compression of the heart and even fetal hydrops, which is a marker of fetal distress. We've learned over the past decade that giving mom steroids can actually shrink these CPAMs. Therefore, we give mother steroids when the lesion is greater than or equal to a CVR of 1.6. If the lesion doesn't shrink or remains large, we sometimes will even repeat these courses of steroids. We have found that giving mother steroids is the most effective way of treating CPAMs that are microcystic in origin or have those tiny cysts. For CPAMs that have a CVR of greater than 1.6 and are associated with significant heart compression or have fetal hydrops, we'll sometimes place a shunt into the cyst when they have large dominant cysts. And what this does is this drains the cyst fluid into the amniotic fluid. And this is one of the primary fetal interventions we offer. As we prefer fetuses with CPAMs to develop their lungs in utero as much as possible, we try to deliver these babies close to term. Depending on the size of the CPAM, we may recommend relocation prior to delivery for those with large lesions who live far away from a tertiary medical center. This recommendation is largely based on the fact that sometimes these large lung lesions need to be removed urgently after delivery.
So thanks, Chris. That was a very good overview of the prenatal management and workup of these babies. As you've said, few of these children need to have fetal intervention at all. Most of the time we're dealing with these babies once they've delivered, hopefully close to term. And in most cases, these babies do not have any symptoms at the time of delivery. They typically don't have to work hard to breathe, and they often do not require any supplemental oxygen. In these more typical situations, the babies will discharge home with the family. They'll be able to eat and grow normally. And then we follow them up on an outpatient basis. The typical recommendation is still to recommend resection at some point, and that's to avoid problems with recurrent infection of these lesions, to avoid potential growth of these lesions where they will affect the function of the normal lung tissue that's remaining. And there's also a small but defined risk of a malignancy or a cancer that can develop in the future related to these lesions if they aren't removed. So in general, again, we let these babies grow for a period of time. We see them back in clinic somewhere around 2 to 3 months of age, and then we typically do some additional imaging with a CT scan. This now gives us a much better detailed anatomy of the lesion itself in order for us to plan what the surgical intervention might be involved. Typically, the surgery can involve either an anatomic resection of the entire lobe of the lung that this lesion is contained within, or if the lesion's relatively small and isolated, it sometimes can be amenable to a more segmental resection or a smaller resection where we do not remove the entire lobe of the lung. And then the other decisions at the time of surgery is if these require an open incision or a thoracotomy incision, which is a larger incision where we go in between the ribs to remove these lesions, or hopefully they're more amenable to a minimally invasive approach, which is where we go in thoracoscopically, typically through 3 or 4 smaller incisions that are 3 to 5 millimeters in size, and we can do the entire operation through these smaller incisions with less scarring afterwards, less discomfort, quicker recovery, and hopefully a quicker discharge home as well. So whether the patients either have an open operation or an operation thoracoscopically, a small drain is typically left in place to help the lung re-expand postoperatively. The drain's removed usually 1 or 2 days after surgery, and most of these babies go home within the first 2 days after surgery, without oxygen supplementation and back to eating and functioning normally otherwise. The lesions are always sent to pathology to make sure that there's nothing contained in there that would need any additional therapy. And long term, these babies do fine and typically don't have any real activity restrictions at all related to these relatively small lung resections that are done when they're very young and their lung still has lots of time to develop and grow.
In summary, these lesions are often identified in utero. They rarely need an intervention performed before the baby is born. We try to have your babies deliver at term, and then we follow them up in a couple months after delivery to plan a resection. The reason for these resections are multiple. One of the advantages of resecting at this time point is that we allow opportunity for the remaining normal lung to compensate for that removed lung. If you have any questions or want to reach out to us, please do so via email or telephone. Thank you.
Thank you very much.